Acute pancreatitis. So first important question that is asked with respect to your acute pancreatitis is regarding the possible causes of acute pancreatitis. So I have taken this table from your Bailey and Love. The various causes of your acute pancreatitis includes your gallstones, alcoholism, post-ERCP, abdominal trauma following biliary or upper GI thoracic surgery, ampullary tumor, drugs like corticosteroids, azathioprine, asparaginase, valproic acid, thiazides and estrogens, right. Then hyperparathyroidism, hypercalcemia, hypertriglyceridemia, pancreas divisum, sphincter of Oddi dysfunction, autoimmune pancreatitis, hereditary pancreatitis and viral infection like mumps and Coxsackie B virus, malnutrition, scorpion bite and idiopathic. Now, if you are asked regarding one of the most common causes, then it is your gallstone, right. So, gallstone is your more important cause compared to your alcohol. Now, remember, for gallstone pancreatitis, the surgery should be done in the same hospital admission, right. So, this is one of the very important questions that is asked. Now, regarding the clinical features, so the pain is the cardinal symptom of your acute pancreatitis. It is usually experienced in the epigastric region and approximately around 50% there is radiation to the back, right, and this is classically relieved by stooping forwards. So, when you see a patient in your emergency setup where the patient complains of an epigastric pain and gives a classical history that the pain is relieved on stooping forward, it gives your hint towards the acute pancreatitis. Then it may be associated with your nausea, vomiting, and then obviously with pancreatitis there would be other features of clinical shock that might be presenting, and on examination there might be tenderness or rigidity in your epigastric region, right. And other specific features seen with respect to your acute pancreatitis include your bluish discoloration of the flank, which is known as your Gray Turner sign, and then we have your bluish discoloration over the umbilicus, which is known as your Cullen's sign, right. Then regarding the investigation, we have your amylase and lipase, right. Please remember that lipase is more sensitive and specific when compared to your amylase, and a positive amylase does not means that it is pancreatitis, as amylase can be raised in many other cases also. Then what are the cases when you would want to do a CT scan in case of acute pancreatitis, right. So, when the diagnosis is uncertain, then distinguish the interstitial and your necrotic form. Then when your local complications are suspected, and you would also do a CT scan when the patient is presenting you with sepsis or your organ failure, right. Now, in acute pancreatitis there are various severity scoring system which includes your Ranson, Glasgow, Apache, SAPS, SOFA and MODS. So, the most important that we would be discussing is your Ranson and Glasgow. So, first we discuss the Ranson. So, Ranson has it basically checks your severity at 2 points, one which is on admission and second within your 48 hours. So, on admission, what are the parameters? It includes age more than 55 years, white blood cell count more than 16 into 10 to the power 9 liters, blood glucose more than 200 milligram or more than 11 millimole per liter. Then we have LDH more than 350 units per liter and AST more than 250 units per liter. Then within 48 hours, there should be a fall of at least 10 or more in hematocrit. Blood urea nitrogen is raised more than 5 milligram per deciliter. Partial pressure of oxygen is less than 60 mm of Hg. Serum calcium is less than 8 mg per deciliter. Base deficit is more than 4 millimole per liter and fluid sequestration of more than 6 liters, right. Whereas in your Glasgow criteria, which is done within 48 hours, right? You have this following parameters: age more than 55, white blood cell count more than 15 into 10 to the power 9, whereas in case of Ranson it was 16, blood glucose more than 10, whereas in Ranson it was more than 11. Then we have LDH more than 600, whereas in case of Ranson it was 350, AST more than 200, whereas in Ranson it was more than 250. Then we have your serum urea more than 16 millimole per liter, PaO2 less than 60 mm of Hg, serum calcium less than 2 millimole per liter, and serum albumin less than 32 gram per liter, right. So, these are your severity scoring system. Then we have an Atlanta classification for your acute pancreatitis. So, what is this Atlanta classification? It classifies pancreatitis into 3 types, which include your mild acute pancreatitis, moderately severe acute pancreatitis, and severe acute pancreatitis. So, what happens in your mild acute pancreatitis? So, there is no organ failure and no local or systemic complications. Now, what happens in your moderately severe acute pancreatitis? So, there is an organ failure which resolves within 48 hours, right. So, it is not a persisting organ failure which resolves within 48 hours, and then there may be local or systemic complications without organ failure, right. So, there is no organ failure along with the local or the systemic complications. Now, in severe acute pancreatitis, we have a persistent organ failure. Now, what is this persistent organ failure? It is more than 48 hours. Then you have your single organ failure or your multiple organ failure, right. Now, regarding the early management of your severe acute pancreatitis, I have again taken this table from your textbook Bailey and Love. So, it includes your admission to your high dependency unit or ICU, analgesia, aggressive fluid rehydration is needed, supplemental oxygen, then your invasive monitoring of your vital signs, central venous pressure and urine output and blood gases, then your frequent monitoring of hematological and biochemical parameters including the liver and the renal function, clotting and the serum calcium and blood glucose. Then we have your nasogastric tube only initially, then that means we do not have to have a persistent nasogastric tube. Then antibiotics only if cholangitis is suspected, and then prophylactic antibiotics can be considered, and usually we give antibiotics only when we suspect an infection. The CT scan essential if there is organ failure or clinical deterioration or signs of sepsis develop. Then ERCP within 72 hours of severe gallstone pancreatitis or signs of cholangitis. Then your supportive therapy for organ failure if it develops, and nutritional support is required, and we need to consider early enteral feeding or at least a nasogastric feeding, right. So, these are your early management guidelines of your acute pancreatitis. Now, again we have a next table that I have taken from your Bailey and Love, which includes the complications of acute pancreatitis. So, the main complications of acute pancreatitis could be divided into 2 groups, that is systemic and local. Your local complications include your peripancreatic fluid collection, sterile pancreatic necrosis, infected pancreatic necrosis, pancreatic abscess, pseudocyst, pancreatic ascites, pleural effusion, portal or splenic vein thrombosis and pseudoaneurysm, whereas your systemic complications include your cardiovascular, shock arrhythmia, pulmonary ARDS, renal failure, hematological, which includes your disseminated intravascular coagulation. Then you have your metabolic abnormalities that include hypocalcemia, hyperglycemia and hyperlipidemia. Then it could have a post-op ileus, and in neurological it could have your visual disturbances, confusion and encephalopathy, and miscellaneous complications include your subcutaneous fat necrosis and arthralgia. So, this is all about your acute pancreatitis. Now, in the next video of your acute pancreatitis, we shall be discussing in details regarding the complications of your acute pancreatitis, which would include your pancreatic necrosis and your pseudocyst.